Good morning and welcome to the Department of Medicine Grand Rounds. The CME code for today is 31636. It's my pleasure this morning to introduce our Grand Rounds speaker, Dr. Marisha Burden. Dr. Burden is a professor of medicine and division head of the hospitalist medicine at the University of Colorado School of Medicine, where she leads one of the largest academic hospital medicine programs in the country. She's also a deputy editor of JGIM, Journal of General Internal Medicine, and a nationally recognized leader in hospital medicine research, clinical operations, and workforce design. Dr. Burden's work has shaped how we think about hospitalist workloads, patient flow, administrative harm, and evidence-based work design, with multiple award-winning studies and national leadership roles through the Society of Hospital Medicine, Home Run, and CMS technical expert panels. She brings a rare combination of frontline clinical experience, rigorous scholarship, and executive leadership. We're delighted to have her with us today and thank Dr. Sugit Jagpal for recommending her. And she's going to be sharing her insights on improving care, work, and outcomes in hospitalist medicine. Thank you, and please join me in welcoming Dr. Marisha Burden.
Great. Thanks, Dr. Cohen and team. Let me share my slides. Move it over. All right. Well, first, thank you all for the invitation. Thrilled to be here and excited to talk about a topic that I'm very passionate on. And first, I wanted to just give a note of gratitude to a couple of entities that have funded a lot of the work, though not influenced the work, but they did make it possible. So we'll be running through the topic from harm to healing, redesigning the way we work. And hopefully, whether you're a hospitalist working in the clinic or a proceduralist in the ORs, whatever you might do, hopefully this talk will be pertinent to you. So, three goals or objectives today, hoping to describe the concept of administrative harm, which may be a new term to some of you, and explain how policy, regulatory, and organizational context can shape the conditions for which care is delivered. We'll review the evidence on optimal workloads and work design and how decisions around how we work can influence outcomes. And then lastly, we'll apply evidence-based work design, possibly another new term, and a precision science principle or principles to develop, test, and refine how we think about designing work. I have three principles I like to cover before we go into a couple of topics that are really hard, including administrative harm. But the first is that we're in all of this together. Second, when we talk about harm, whether it is clinical harm or administrative harm, harm is a tough topic. We're dealing with all good people, and sometimes our decisions can go sideways. But I always preface it that it's not an easy conversation, whether it's clinical or administrative, and sometimes we can cause both. And then lastly is that we are all leaders. So even if you're very early in your career, maybe no formal title, if you sit on a committee or you can influence decision makers, you can be part of that. And obviously, we often think about high-level leaders potentially causing harm, but we can all kind of contribute if we're not careful. So I wanted to start today's talk with a case of Dr. L. Now, Dr. L is a hospitalist, and she is on day 6 of 7 of a very busy inpatient service. And she's already gotten up very early this morning because she knows that she's starting off with 18 patients, and she has an impossible day ahead of her. Not only does she have a ton of patients to see, but the pressures for which she has to work under are intense. She's expected to try to discharge as many highly complex patients as possible well before noon. She needs to call all of her consultants, ideally before noon. Of course, the patients and their families are anxiously awaiting their care plan for the day. So many things have to happen. She will send and or receive about 130 secure messages about her patient's care, and then she'll get called to the bedside of a patient who's not doing well. She'll order lots of tests, talk to the nurse, and her plan is to come back in about 20 minutes. But in the middle of all of that, she gets called some urgent labs, and then another patient's having trouble. And before she knows it, it's been at least an hour, and she gets the alarm bell going off on her phone, which is the kind that you don't want to hear, and a code in that first patient's room has started. Dr. L rushes to the patient's bedside. The ICU team is there, and the patient is eventually transferred there. The nurse is frustrated with Dr. L. She couldn't reach Dr. L. What was Dr. L doing? But Dr. L will own the decisions that she made that day. And in fact, there are procedures and policies that the organization has built to help us evaluate why that patient's care could have gone better. There will be root cause analyses. There will be all sorts of assessments about how Dr. L and the care team could have done it differently. But what if we were to look a little more upstream to about a year before? And Dr. L's care team had decisions made about their work design. And I am one of those people that sits in those rooms and tries to think about our financials, try to think about what should the optimal work design be. But when we look at that case for which Dr. L will be scrutinized and potentially even have a lawsuit for, those upstream decision makers often are invisible. And those decisions really aren't thought about how they might have impacted Dr. L and perhaps all of Dr. L's colleagues and all of the patients that they cared for. You can take it even further upstream, which is around policy related decisions. And policy related decisions can influence how institutions, organizations get paid, which will ultimately impact staffing decisions and work design decisions. So you can see how all of these many different upstream decisions can play out directly at the bedside, potentially causing administrative harm. So, administrative harm may be a new topic to you all. I think it's starting to gain more attention nationally and internationally, but it still may be new to some of you. Administrative harm was originally coined by Dr. Walter O'Donnell in a New England Journal of Medicine article back a couple of years ago, so it's relatively new, though I think the concept is not. And then we were had the opportunity to do a study on the concept as well. And so between all of those different works, here's a working definition to consider what administrative harm might be, which it is the adverse consequences of administrative decisions within healthcare that directly influences patient care and outcomes, professional practice, and organizational efficiencies, regardless of employment setting. Now, you can be a high level leader, as I mentioned before, not even have a formal role, and still potentially contribute to harm. So when we did our large scale qualitative study, mostly of physicians and hospitalists, I'm going to share some of the findings and walk you through to hopefully paint a picture of what administrative harm is. And then we'll also talk about how we think about mitigating it. So we had, I think it was 41 participants, which for a qualitative study is a lot of people, that represented 32 different organizations. This was published in JAMA Internal Medicine 2024. We like to embed very brief surveys within our qualitative work, and these are just a few highlights of those survey findings. The first was we asked participants, how do you think about this question in your organization? My healthcare organization prioritizes clinician health and safety. Only 6% of participants could say that to a great extent. Similarly, my organization encourages transparency and accountability in decision making. Only 9% could say that. And then I have witnessed instances where administrative harm has led to adverse patient outcomes in my healthcare setting, 85%, somewhat to a great extent. So harm is happening. Next, I will cover three themes that we found through this same project. And then I will share with you an exemplar quote because I think the words of participants are very powerful in this study and many others. The first was that administrative harm was felt to be pervasive and come from all levels of leadership with wide-reaching impact. So again, this is not isolating it to administrative leaders. It's not isolating the phenomenon to high-level leaders. It's recognizing that just like in clinical care, when we make decisions, they can sometimes unintentionally go sidewards. Now, everyone felt that administrative harm was everywhere, but only 6% of the participants were actually familiar with the term to a great extent. And as I shared with you before, 85% of participants noted that administrative harm had actually led to patient harm somewhat to a great extent. Here's a quote from one of our participants. A great example of administrative harm is the theme of when we have complex systems and we require physicians or clinicians to work themselves through that system because we don't have the capacity to make the system better. The second theme was organizations lacked mechanisms for identification, measurement, and feedback related to administrative harm. Go back to Dr. L's case and think about if you were in that same situation, what are the structures and processes to address potential either harm or when care goes accidentally sidewards? We have safety reporting systems for which we can mostly rather easily report when things don't go as planned. We have committees that may do root cause analyses. There's a wide array of structures and processes built to understand how we optimize and build better care and also improve our decision making. But you don't see that as much in the administrative world. Now, the sad thing that we found was that even though our participants were predominantly physicians and predominantly leaders, only 38% of participants felt that they were empowered to speak up and raise concerns. So not only do we not seem to have structures to identify and measure and give feedback, even leaders, physician leaders, didn't feel safe enough or empowered to speak up. I've never heard of somebody measuring from the administrative or hospital side that this kind of harm even exists. And most of the time, what happens is we are asked to do a task, and that is not a question. We couldn't get echoes on the weekend. Have seen many examples where inadequate staffing is tolerated because we know that thing needs to be done and we will get it done somehow. And you can always get an underpaid trainee to do the work. Third, organizational pressures were felt to drive administrative harm, and there were characteristics of decisions that result in administrative harm. A very kind of prevalent example, I think, of administrative harm is when we look at our healthcare systems. This is not just a US phenomenon. They're often busting at the seams. And in my world, as a hospitalist leader, we're often asked and participate in decisions around trying to improve throughput and capacity, which we need to do. But what our previous work has shown is that we often use kind of low yield strategies. And one of those strategies that I've been personally plagued with in my career and also personally caused was that we would send texts to busy frontline clinicians, reminding them that one, it's really busy and they're well aware, and two, to not forget to try to rapidly discharge, name your target number of patients by your target time, usually by noon, 10 a.m., 11 a.m. Now, we happened to get funding to do a randomized control trial because this strategy is so pervasive across U.S. hospitals. And in that randomized control trial, we found that it actually, the strategy of prioritizing as a sole strategy, discharging patients first, didn't actually work. And what we found in the qualitative comments in all caps was frustration, frustrated that you made me do this thing when I knew it wasn't going to actually expedite my day and it caused rework. So these are examples of sometimes well-meaning decisions to try to have better outcomes, but then it kind of goes sideways. We feel pressured to do something, anything, even if it's a low yield text. Now, the bright spot in all of this is that 100% of participants felt that collaborations with administrators and clinicians was really critical, somewhat to a great extent. It was a business decision made by business folks without any clinical input. Where does that come from? Is folks not understanding, not being at the bedside, not engaging frontline workers, and not having a clinical background, and not reaching out to understand if I make this decision, yes, it fixes my budget, but what ramifications does it cause downstream? Now, this was not a full-fledged theme, but it was a cross-cutting thing that we noticed. So it didn't quite surface to the level of a theme, but it was around the concept of third-party consultants. Now, remember, the qualitative focus groups were focused on administrative harm. So this will be sort of the administrative harm side of third-party consultants, but they surfaced. And what we heard from many different participants across focus groups is that external entities, so these are companies that health systems may pay to come in to do a variety of things, such as funds flow or thinking about compensation models or how you might structure work design. They are influencing work design and work environments across US healthcare systems. This is a very powerful quote. And again, I think on a different topic, it wouldn't all be, flavored in this negative light. It was the focus was administrative harm. So just remember that. I think third-party consultants also do good as well. But in these projects, this is what our participants shared. We actually paid a very high-cost consulting company to tell us that we needed to eliminate our administrative time and staff to 18 to 20 patients per hospitalist and cut vacant positions, and the list goes on. They were the consultants who told us how to do these cost-cutting measures. They were being paid a ton of money to tell us how to do our work and trying to create a burn and churn program. So, if you can't quite tell, though I'm sure you're feeling it, we are in the middle of a perfect storm in healthcare. And I have had the opportunity to go to lots of different places across the country over the past many years. And you see the same things play out, where it feels like sometimes our organizations and the people within them can feel like there's conflicting goals. We have limited resources. I'm not sure that ever goes away. And then there's really more uncertainty than ever. And when you have conflicting goals, limited resources, and uncertainty, we often make decisions out of scarcity and in a very short-term mindset. I wanted to share with you a couple of trends that I'm sure you're well aware of as well. These were really important articles that highlight the challenges that I think we face. If you're in the outpatient setting, the Journal of General Internal Medicine article highlighted to me as a hospitalist that the work that primary care clinicians are trying to do, if you're not in a fully team-based setting, is impossible. So you're trying to do all these guideline oriented strategies for your patients, and to do all of those things that you're supposed to do exceeds 24 hours in a day. If you have a team-based care model, it gets better, but you probably don't have time to take a break, such as eat lunch, go to the bathroom. Our worlds are very busy with not enough time to do what we need to do for our patients. If you look at the left lower quadrant, this is more in the inpatient setting, what you see is that patient complexity is increasing. I've almost been practicing for 2 decades, and the staffing models and work design models have not significantly shifted based on what I've personally experienced, yet our patients are more complex than ever. In the bottom right hand quadrant, what you see is that no matter what your specialty is, there is a reasonable chance that you are thinking about either reducing your effort or moving on. And in fact, the studies would suggest that about 30 or a third of the physicians across the U.S. Have some intent to leave their current position. We have a couple of studies that are not quite out to the world yet, but one of them will actually highlight, I think it's about 70% have intention to reduce their clinical effort because the work has gotten so challenging. Then adding all of that, more fuel to the fire, is there's money to be made in healthcare, apparently. And so what you see is private equity is entering a lot of different spaces. And then another trend that we're also seeing is that physicians are actually starting to unionize. And while this has been more in the private sector, it's actually also happening in some academic settings as well. And so lots of things are happening within healthcare that will influence kind of the future direction. So there's lots of things going on: burnout, moral injury, intent to leave.
Right,
Uh,
Danny?
Whoop, I think. Um, so lots of trends are happening. Like I mentioned, burnout, moral injury, um, payment models for the services provided, all very shaky. But what gives me hope is that many of these challenges that we're facing stem from modifiable work structures and processes and environments, and are therefore, in large part, preventable. I want to share with you a story of my dad, actually, who went through kind of a wild journey in healthcare over the past decade. And while I could tell you so many stories, I will focus in on one. Now, my dad was diagnosed, and this was years ago, with a squamous cell carcinoma of his temple. He had had a Mohs surgery, and then unfortunately, several years later, it recurred, and it recurred deep, with a CAT scan showing that it was very aggressive and nearing the structure of his eye. We would face many, many different delays. And ultimately, it would culminate in him landing in the emergency department about a week before his surgery had finally been scheduled. Now, my family in another state landed in the ER. It was horribly busy, and I'm sure all of us have had some similar experience where patients are just flowing into the hallways. There's not enough people to actually get the job done, and so you wait and you wait and you wait. And then my dad had had a CAT scan to see why his eye had swollen shut as he was awaiting for his surgery. And a very busy physician would come in and tell my family that they were concerned that he could possibly have malignant melanoma. when his original diagnosis in the same healthcare system was squamous cell carcinoma. Now, my mom, who has a doctor on hand as well as a pharmacist in the family, quickly called to be like, why do they think he has now possibly melanoma? And my family characterized this doctor as a potentially dismissive doctor. And I sat for a moment. Why would someone in the same healthcare system come in and accidentally mislabel a patient who very clearly had a very different diagnosis? But I wanted to share a story that goes a little upstream, similar to Dr. L. So we're going to go not only a year upstream, but years. And we're going to think about how business and medicine training goes. So I, at one point in my career, decided to get my MBA, and I take lots of classes to try to understand the business of medicine. But in that journey, one of the most interesting exercises that I got to do that I think was directly pertinent to my dad's case goes like this. You're given a sheet of paper and you do group work a lot in these types of classes. And I was given a clinic who was trying to optimize to get more patients in so less patients would go to the urgent care. And there was this poor APP who had to see 18 patients. And the theory was that she could be optimized because she had idle time. It turns out, if you're not careful, idle time can look like the time that you're actually reviewing patients' charts, for example. Now, I'm an A plus student in general, and so I was determined to get an A. So I optimized that APP from about 18 or 20 patients to about 40. I did put an asterisk that said, this actually isn't truly viable because one, nobody would take this job. Two, we all know what happens when we get too busy. You're probably going to take even more minor conditions and send them possibly back to their urgent care clinic, and patients don't get optimal care. But in that exercise, the sole goal was trying to optimize the number of patients seen without looking at the sort of balancing measures of, is this actually viable? Could patients get good care? What would happen if you had too many patients? And so when I think of this case of the seemingly dismissive doctor, who was probably dismissive, in fact, by design. So as humans, and maybe the AI bots and all the AI technology will change this, we do have breaking points. And there are many studies that will actually suggest that there are points at which then our performance starts to decline. So I'm kind of obsessed with thinking about what is the optimal point. No one wants to be underutilized, but we also don't want to hit that tipping point of breaking or harming a patient. I want to take a moment to ask you two questions, and virtually this is a little harder, but think to yourself about the following two things. How many of you apply science or evidence-based practices to your everyday work? So you're seeing a patient in front of you. How many of us on this call, and you can raise your hand or a virtual hand or just think about it inside your head, how many of us do this? Now, I have the opportunity to go to a lot of different places, and 100% of people in these rooms, virtual or not, raise their hand because this is what we're trained to do. And if you don't do it, you're going to find yourself in hot water. But the second question is a little trickier. How many of us can safely say that when we have evidence-based practices around our work design, so that could be how many patients you see in clinic, how many patients you see as a hospitalist, how much time you get, how many of us can safely say that when we have that definitive evidence, and that secondly, that we've implemented it? Now, I will share that having gone to probably more than 50 or 60 places in about the last 2 years, there are maybe a handful of hands that go up and they come up very cautiously. Because the truth of it is we really don't have the evidence base yet that we're working to build it, and we certainly haven't implemented it. Now, we do have some evidence to suggest that there are these breaking points or tipping points where performance starts to decline. And I will say, I have to give a shout out to the nursing field who has done so much in this space, but there's more work to be done, and specifically in the physician world. About how we think about our work design. But this is a prime example done by Dr. Linda Aiken and her team. This is an older study, but it's so powerful because it shows that staffing matters. And in this paper, hospital nurse staffing was associated with patients dying, nurse burnout, and job dissatisfaction. So these are not minor, oh, let's try to figure out, a ratio kind of thing. These are, we have to figure out our work design because patients can die. In the hospitalist world, this is a pretty consistent finding that there are workload thresholds at which length of stay actually exponentially goes up. And I don't have the exponential part of this picture. But think about how our organizations think and have so many committees about how we try to improve length of stay. But we never want to be brave enough to go and think about what would be the work design and work structure because we often think about it in that very simplistic business sort of way, which is, oh, it's going to be more costly. And there are studies actually that now show that it's actually more costly to not get the staffing design correct. In fact, millions of dollars. In this article, you can find it did not make its way into sort of the mainstream medicine world, but it did in the business world. And my colleague, Dr. Masood Kalmamadi, did just this. And he looked at hospital staffing in the private sector and then as well as in an academic hospital. And what he found is there's kind of a Goldilocks principle of certainly too much, even too little. But if you go on the too high or too little side, it actually costs you, in fact, millions of dollars. Which gets me to what I call the $11 million problem or conundrum. And this is something as a hospitalist leader, I jumped into hospital medicine leadership very early in my career. So fumbled a lot, learned a lot, but had a lot of the same conversations both in my own healthcare organization and then also seeing colleagues nationally struggle. And what the $11 million problem is, and it's not really 11, you can change the numbers for your negotiation in hand, is how do we know what resources we need to staff, for in this example, a hospitalist team, but you could also argue primary care or how you staff a lab for procedures. But the $11 million question gets at who's right in these arguments. And what I've found through many heated ones is that we come with a lot of subjective opinion without evidence. And these can be sometimes fiery conversations. But one of these ignited what I call a spark, and that spark turned into a flame. And I will share with you some of the work that we're doing on this. So we've talked about administrative harm, which is not too different than how we think about decision making in clinical care causing harm, just a different context. But if we have administrative harm and we believe that there are ways that we can approach our decision making to do better to minimize harm, here's a lovely framework that a colleague and I put together, and it's in the New England Journal of Medicine from 2025 on the concept of evidence-based work design. And if you think about in the clinical realm, we have evidence-based medicine. And so we really tried to mirror this concept from evidence-based medicine so that the two kind of align and starting to think about how we build structures and processes to support evidence-based work design. And so this figure did not make it into the article, but I like to put it in my presentations to give you a nice conceptual model for what we're talking about. So we're utilizing the best evidence. I've shared with you there's some, we can do more, and we're actively trying to do more of this day by day. Bringing in clinical and administrative expertise together, we need both. Being very data driven, and then doing rapid iterative improvements. No longer do we just implement a work design and let it play out for decades. We're going to actively understand if it's working and getting the desired effect. And it's going to influence how we as decision makers in our organizations decide about job demands and job resources so that hopefully we can get better healthcare worker safety and well-being outcomes, operational and financial outcomes, and patient safety and quality outcomes to get finally, hopefully someday in the future, to a thriving healthcare system. Now, when that little spark turned into a flame or a fire, we started to build a research agenda around this topic of what does optimal work design look like. And I'll very briefly walk you through what we've done to date and then where the work is going to in the future and hopefully build some excitement. And we'd love to collaborate. So the first thing that we did to build the foundation was to think about what are the measures for how we think about work design and workload. And two of the things that come to mind when I raise this are work reviews and encounters. But what we found when we did scoping review, which was entirely painful and resulted in way too many articles, something like 6,000 or so, and an expert consensus, so a Delphi panel where we talked with C-suite level leaders, human factors engineers, frontline healthcare workers. What we didn't hear was that work reviews and encounters should be the only measures. Now they are part of the measures, but there were so many more. And thinking about how outcomes then play out when you think about targeting work reviews or encounters. So bringing in another element to that equation. And then also thinking about cognitive load and other elements of workload that impact our outcomes. We started thinking about rapid methods. So we don't have years to figure this out. We need to figure it out right now. So we did a lot in the way of rapid qualitative work, which you got to see with the Administrative Harm Project. But we've done so many projects using those methods where you can get results and findings within weeks. Publication takes a little bit longer because of processes, but you can have findings rather quickly. And we actually used those in the pandemic when we were trying to figure out operational best practices. We're kind of diving into rapid trials and rapid systematic review. So everything in my world needs to be rapid. And then determining and predicting outcomes. And so no longer can finances only be the sole goal. It has to be patients, workforce, and organizational, because if you don't have all three, then you don't have a viable organization. And so this is how we're getting at this concept of evidence-based work design, thinking about this left side of the equation to get to the outcomes that we all want to hopefully be the best organization in the country. Then we were able to get a small grant that we did so much with, and we built an app. You can check out our work on grittywork.org. But this is a mobile application that we built because what we heard is that the every other year or every year wellness survey wasn't quite cutting it. On the flip side of that, what you also don't want to do is burden busy clinicians with more things to do. So we built an app made for and by clinicians to do quick pulse checks to understand where you're at. Are you happy? Are you sad? Hopefully, in the future, we're going to be able to truly bring in some of the physiologic data, which we have not yet done to date, but there are plans for that. And then looking at different measures of workload, such as NASA TLX, which is looking at how cognitive load may vary based on the service that you're doing or the work that you're doing. So we do brief pulse surveys. Goal is less than 5 minutes. And then what we've also tried to do is only ask the questions that we can't digitally acquire. And I'll show you what that means. Within our electronic health record systems, every click, everything that we do as clinicians is captured, which is both cool and a little scary all at the same time. But you can see patterns of work without asking busy clinicians to do more. So, as a hospitalist leader, we look at these patterns a whole lot. Are people getting out roughly when they should? Or is it kind of going into the wee hours of the evening or morning? Excuse me. And so these are great pieces of data to help bring a picture of either overwork, underutilization, et cetera, without asking anybody to do an additional thing. And so what we've worked to do is to understand what are those measures that are in there so we can tell how much work someone did on a given day. We know how many different communications that they had, digital communications, to try to get at what do we actually have to ask a human. We were able to get an American Medical Association award. We use survey data, audit log data, patient outcomes data to try to understand what are the most predictive factors of burnout. How do these measures, these digital measures, pair with what the clinicians are experiencing? And then could we pair them with patient outcomes as well? Now, this is not yet published. It's coming out. The manuscript's almost done. But this is a very busy slide to show there were lots of associations. And we used higher level aggregated data in Epic that's called Epic Signal. And you can see lots of different variables had correlations. And now we're actually working to build machine learning algorithms to kind of predict a variety of outcomes. Excuse me. So here is the dream. So we're taking little pieces of surveys. We're taking audit log data, which is that digital clickstream data, trying to minimally ask busy clinicians to do more, using those digital footprints or fingerprints, if you will, and then also bringing in additional data sources. And so I recently got a rather large grant that's a very fast one. Work has to be done in about the next 4 to 5 months, where we're actually looking at clinician communication data and trying to use LLMs to understand at the team level, is a team thriving or are they struggling? And pulling those together in something that we're calling grit signals, and then using all these different data sources to build a near real-time analytics module that we're calling the Gritty Work Safety Management Platform to identify emerging work design harms. So if we decide to change the workload of a clinical team or change a clinical structure, we are going to know in fairly near real time, are there signals of harm or is what we intended to do playing out and therefore hopefully thriving? And then our goal is to actually forecast harm before it happens to help leaders make better decisions And you can see it's a rapid iterative cycle of constant optimizing for outcomes, patients, workers, and organizational. Now, here's a sneak peek. The world has not seen this yet. This is just a mock-up with very fake data. But as we build our safety management platform, what we want to do is help bring data to these conversations, but data in a different way than you've really ever seen. So if you go back to that $11 million question, which $11 million, $12 million, whatever the dollar amount is, highly subjective debates happening. Imagine if we took data such as this to say, here's what we see on the outcomes that you care about. What we see is that 12 patients in this local context, at which after length of stay goes up. So then it becomes a conversation of trade-offs. Not that I want to give you or don't want to give you an extra $1 or $2, but now we're going to have a conversation about the actual outcomes of our decisions. You could imagine having conversations around mortality too, which is if you understaff it, patients could die. Are you okay with that decision? So I think it fundamentally changes the framework for how we make these operational decisions from subjective to more objective. Similar with team structure and so many other variables that we're trying to understand. So similarly, you could kind of do a slider bar, and then based on national data that we've also built models from, but then also using local context, you can kind of do a slider bar with these underlying models to say, okay, if we targeted 12 patients for an MD-only team, what would be the outcomes based on our local contextual data? Or let's change it up. Let's run it at 16 and then do an MD APP model, and then the model would actually output outcomes based on what you've seen locally, hopefully with AI recommendations. That's to be done in the future. And then here's where I think the real money is at. So money matters. Money helps us have our missions. And so you can't have financially non-viable models. But I think we often look, if you go back to the perfect storm, we're making decisions out of scarcity. So we're going to always take that short term, what appears to be cheapest option. But as I showed you in that previous work, length of stay matters for hospitalists and it costs organizations millions of dollars. And so on first pass, perhaps that physician seeing 15 patients by themselves seems to be cheaper. And yes, it is on that spreadsheet. But when you start to look at other outcomes, the mathematical models start to change. And so what we're hoping to do with this work that I've shared with you today is to bring this type of data to decision making, to bring a more holistic picture when we're having these very hard conversations. So imagine if we go back to Dr. L and we start to think about those upstream decisions a little bit differently, perhaps characterizing the risk for administrative harm and how we think about our decisions and the real impact that takes place at the patient's bedside. If we think about the case of my dad, where it was a seemingly dismissive doctor, I think we have to think about, is it truly a dismissive doctor or a dismissive doctor by design? And how do we build health systems that help support our clinicians to do right by our patients? And then third, thinking about evidence-based work design, which is to me the solution or how we actually get away from administrative harm. And then imagine that 11 or $12 million conversation going very differently, where it's no longer about that. Do I want to give you $1 million extra today to hypothetically have your team be staffed better? Instead, saying, well, these are the outcomes that are going to happen with length of stay. Patients could die, people could leave, and it's going to end up costing you way more in the way of millions of dollars than actually staffing it right in the first place. So imagine if we got the evidence-based work design. So with that, I'll just leave a quick note in my email. We love to collaborate. We collaborate with tons of people nationally and internationally. Feel free to email me. We would love to understand, one, if you're interested in partnering, and two, I get to learn a lot about different worlds beyond hospital medicine. Our dream is to build these evidence-based models for hospitalist work and beyond. And just a big thanks to all of you for your time and just grateful for the invitation. Thank you.
Wonderful. Thank you so much. And if anybody wants to unmute themselves to ask any questions, or you can post questions or comments into the chat.
Hi, this is Vicky. I'm the medical director for palliative care and the lead physician for the adult palliative care service line. Really appreciate your insight and your research. I can't thank you enough. I think this is the kind of work more doctors need to do. I would absolutely love to see a world where most CEOs, CFOs, and COOs are physicians and COOs, CFOs, and CEOs, like the Mayo Clinic model, which is the only model that has sustained itself for, you know, tens of years without having excessive burnout. They have a very balanced workload and expectations from their doctors, and they do not put the cart before the horse, if you will, because there are physicians in charge in place. And I think more of that needs to happen. So thank you from the bottom of my heart. And I would love to collaborate with you. I will email you.
Yes, I would love that. Thank you. And I think to your point, work design matters. It drives all outcomes in my world. And
Absolutely.
yeah,
Thank you.
thank
You're
you.
beautiful inside out. Thank you so much for being there.
Thank you.
Dr. Clark, you had a question?
Thanks so much. This was a fabulous talk. I'm sure we know many similar people in the hospital medicine and SGIM world, but I don't know that we've met. Um, and I also will invite many people to watch your talk if they weren't here today. My question is whether you've had an opportunity or started to think about, you know, the teaching services and the model of teaching services and thinking about the balance of, you know, care versus teaching and value and quality of teaching and those sort of things. I think in academic centers, that's also something, you know, where the pressures are pushing and where, you know, trying to also manage, you know, sort of, I don't know, three constituents, if you would. Thank you.
Yeah. Great question. So we have like a whole other, I guess I would call it module, where we're looking at trainees. And so our team is huge. And so we're actually recreating, we started in the hospitalist world, and now it's like moved a step parallel to include now the trainees. And so we're actually looking, we call it gritty work. Everything is like a movement around building better work, but gritty work suite of questions and tailoring them actually to trainees to understand what does optimal learning look like, and then pairing that also with the outcome. So I think it's going to be very similar, but slightly adjusted for their needs. And then similarly, we hope to do this in the surgeon world, and it's going to be it will all look a little bit different. One of the questions I get is, you know, are you going to be able to say, this is the ideal workload, like here's the number? And I don't think that's really ever going to be the goal. I think you have to take into account local context, and then it's a conversation of trade-offs. What we are seeing in the education space in our work, that, you know, we're looking at preceptors as well. So even in outpatient spaces, and there's this pull, right? Which is you've got to do X amount of patient visits to maintain your salary. And at the same time, you're supposed to pick up additional students. And what you can sometimes see in some of our national work is that preceptors or potential preceptors are opting out because there's too much tension there to try to get this other work done. And then there's almost either a trade-off of your salary and or your sanity because you can't do all those things. And so I think it's important, if education is a mission area, how do you build that out? But then also, you know, keep the lights on, keep all missions alive. So lots of work happening in that space.
A wonderful talk. I'm a psychiatrist, so and I do research as well. And the challenge has an extra level up that maybe there's a way, and I'd be happy to collaborate with you that we could add to a component of what it means to connect with the patient, because the efficiency that you can get if you have a therapeutic alliance is much better. As you alluded to with your dad, you know, it makes a difference. And yet it's not that it takes more time, but the approach becomes very important. And as Jean was pointing out, you know, how we teach that to our residents becomes a really powerful tool. I'm not sure how we add it. I thought it was great that you have a lot of data that we can just pull from the electronic health record, but you did make the point that there's also the live face-to-face part of it that somehow you have to measure. And I think it's a real challenge. You might already have some ideas how we measure, because there are some teams that really connect with the patients and they get through quickly, and other teams where, what are the reasons when you can't get out of the patient's room or you can't get the patient to do what you want? It's therapeutic alliance, but it's a not so cookbook. Any thoughts on that?
Well, that's a very complex question. So I don't know if we'll be able to measure everything always and nor should we probably, but
Right,
there
right.
are emerging technologies. Our organization rolled out to everyone ambient scribing technology. So conversations are being measured, and technically you could study, that. That sounds like it's not what I'm doing, but somebody on this call could to try to understand how you build trust quickly. Personally, I do believe you need some component of time, and what we're seeing, we're actually doing an administrative harm project with patients to understand their perspective. And it's very interesting. There's a lot of national initiatives around building physician trust with patients and vice versa. And what we're hearing from our patients is the system is so hard to get through. And sometimes physicians are and clinicians are lumped into that. So it's hard to understand that, your doctor wants more time with you, but they can't, right? Because you're held to very quick appointment times. And so that trust is broken when you don't get that time with patients and they don't understand that you really want to spend time, but that, the structure of work and the reimbursement models don't necessarily support all of that time, which hopefully we can change. Because I think some of this is also a bigger upstream conversation around how do we reimburse our work appropriately so we can build those therapeutic alliances with our patients. Very complex
I
question.
put my email in the chat.
Oh,
I'd be
great.
happy to connect with you more if you
Okay.
want to talk more about
That
this.
sounds wonderful. I'd love to.
I'll go if nobody else is. So I'm Catherine Monteleone. I'm a professor of medicine. I'm also the president of our faculty union. You would find our system
Oh, wow.
fascinating. We've had a union here for 50 years. And yet in the last decade, we've been sold, our clinical practice is basically, they say aligned, but it really was sold to a health system. So it's a whole new dynamic. And
Mhm.
it's it's a fascinating system. It really is. If you ever want to talk to me about
I
it,
would love to talk to you about
yeah,
it.
it is. And sitting in negotiations, we do surveys of what workload has been a major issue. We have retention problems. We're always losing people, and workload,
Sure.
is a big part of that, and the lack of feeling validated when you're working really hard, and yet you're being told always to do more, more, more.
Sure.
We have things like Press Ganey, which is, in my opinion, horrible to use on physicians because you get a small N and you're told that you're not doing a good job. And yet, your patients keep coming back and people feel beaten down by that kind of data.
Sure.
So it's an interesting thing. I mean, I've spoken to physician groups across the country about unionizing. I think that's the only way we're going to survive as physicians in these systems where health systems and private equity are buying up our practices, and we have no voice unless we have a real political more political kind of system behind us to speak for us.
Mhm.
But if you want, I'll put my email in the chat, and I think we have people you would love to speak to because we've done a lot of this work and we have a lot of data and
Yeah.
not that we've published, but that we've gathered.
Sure. I would love that. We actually have a manuscript that was just accepted where we looked at in the hospitalist world as a starting point, the unionization trends and kind of perceptions around the private equity entry into healthcare. And it's very interesting, at least in this group, it's a national cohort that we spoke with. They had a slightly negative angle towards unionization, but it was sort of seen as like a tool of last resort, which is we don't want to have to do this, but we will do it if we don't feel like we have voice and agency in our work. And I think about the case of Dr. L a lot. So that first case that I mentioned, if you don't have voice and agency in your work, but yet you're held accountable to the outcomes of patient care, I think that's where the moral injury starts to happen, which is you sometimes feel helpless when you're in that situation, but the fault, the lawsuits, all that kind of lands on you at the individual level. So I've been thinking about a lot of that. And then most importantly, how we get voice and agency to clinicians to help craft their work so that we get better, outcomes across the board.
Oh, hi, I'm Sabia. I don't know. I'm sorry. I'm actually talking to you from Costa Rica.
Oh, that's
Um,
nice.
I'm here learning. I'm here learning about the healthcare systems here, but also about experiential learning and how we actually bring this into the classroom. So anyway, what I wanted to ask you about, and I think your work is great. I think it's really important. But in terms of, where do we actually start this work? Because I feel like, the way that the healthcare system here works is that they actually have a multidisciplinary team that is in the community. So they have a physician, they have a nurse, they have a pharmacist, a pharmacy technician, and a community healthcare worker who takes care of around 1,200 individuals. So, though they know their patients, they know who's vaccinated, they know their blood pressure, they know their diabetes, and they know them when they leave the hospital. So you have this sensation that my patient, even though I've taken care of them in the hospital setting for 3 days, I know that they will be taken care of when they leave that hospital. So this idea of where are we, where do we actually focus our attention? Because yes, of course, we want them out of the hospital. We want them to, and we want to make sure that they're being taken care of by multidisciplinary teams while they're in the hospital. But looking at the actual system, and how we're actually teaching about the system is also really important. And so I think that, as we look at this, at any of these things, we realize it's an onion, and it's so deep. And I just think that, there's so many levels to looking at this. And have you guys been looking at like what are we doing in the community space? What kind of sort of multidisciplinary teams should be occurring in that space? And I'm saying this as a pulmonary critical care physician, so but I see that that's where it has to sort of start.
Yeah, I mean, you're raising so many important questions and it's so big, but that's where I think like all of us can contribute in different spaces. But the problem, that I started out just in hospitals world and then, I'd go give grand rounds and then everybody's like, oh, no matter what kind of clinician you are, same problems are being faced. And so then it grew out even larger, administrative harm, evidence-based work design. And then folks started asking, well, what are you doing at the policy level? And I'm thinking, oh my gosh, I could never sleep and still not get all of this work done. So I would just say every element is important. And what I'm learning is the further kind of upstream you can go, the work can be even, the scale can be even bigger. And so our work is a little bit shifting even at the policy, like how do we think about policies and guardrails to make sure that safe work is happening. I don't know if I have a perfect answer for you on this one, other than it's really hard, very complex, but there are so many talented people on this call that collectively, I think we can solve it.
Dr. Brandt, did you want to ask a question?
Yes. So thanks for this great discussion. I was wondering if you looked into the impact of insurance companies and their demands. We spend an incredible amount of time, especially in our tertiary quaternary referral, for
Yeah.
getting prior authorizations. And I remember just with one patient recently, probably the amount of time we spent was about 3 hours, only to have it refused. And thinking, boy, amount of time that we spent could probably cover the first 2 weeks of doses for this patient. And this is something which there's no controls, and there seems to be no administrator or and contracting decision making with when you decide to have participation with the different insurers. But it's just this black box, if you will, of physician and staff time.
Yeah, no, it's a really big area of interest, and the Administrative Harm Project for Patients that is actively underway. Based on some of the focus groups I've had an opportunity to listen to, when we ask patients, tell us about administrative harm, they're saying the same thing. They're like, it's like a full-time job to try to navigate insurance. And I think a couple of important concepts come up that came up in our original work around decisional distance, right? So the further you are away from the impact of your decision, you're almost blind to it. And so I think some of that plays out with insurers, right? I mean, it's easy to say no when you don't see that struggling patient, so far away. or are you're not liable really for the bad outcome that may happen to that person. And so, and then you're talking about the clinician time and effort and harm done to them that is not frankly reimbursed when you could spend your time other ways. So it's something that's top of mind for us. I hope our next administrative harm paper will hit big and cause like a nice conversation around how do we kind of close this gap and make it a little easier for patients and clinicians alike. I don't know. I don't have an answer on this one either, but it is going to play out in our next work. The stories from the patients on that are so powerful and really alarming, though not surprising because we hear those stories every day.
Thank you.
Dr. Patel? Manish?
Yes. Hi, Howard. Can you hear me?
Yes.
Hi, Dr. Burden. This was really a fantastic presentation. Thank you again for coming and showing us some of the great work that you're doing over there in Colorado. And you guys have been a leader in the hospice field for many, many years, including the pipeline that you have established to staff your hospice service, both on the APP as well as the physician side. So I'm one of the academic hospitalists here. I wanted to ask you a question. You know, your talk is more timely than you realize here. We are ourselves experiencing a perfect storm of a surge in patients from our winter respiratory viruses, coupled with staffing shortages in our hospitalist service. And I think that many of the hospitalists, if I can speak for them, and my apologies for doing so for those who are on the call, are feeling the burnout and the stress and seemingly not feeling like we can come out underneath the foot of what we're experiencing. So short of the amazing the language model that you are developing, which I know will be put out, and I think could really change and individualize and almost like precision medicine help us with staffing issues. Do you have any advice in terms of what readily available data at hand that we can use? We are an Epic, I'm sure as you are as well, that can help us to go to our administration to show what some of the staffing challenges and also maybe what some of the solutions perhaps can be. And I'll throw in there as well. I'm sorry about the loaded question here, but I'll also throw in here including team-based models, physician APP models, in which our current staffing is that we have wonderful APPs on our hospital service, but they mainly do admissions and cross-curving at night. We don't have a team-based model. And so anyway, I'll stop there, and I apologize again for the long question.
Yeah, excellent question. And I would say many hospitals groups, and you could probably extrapolate to every group, is facing similar struggles. And if you want, I can also schedule a call with you, after this, just to try to help too. But my general approach, I use data in extreme ways. So I have every benchmarking report possible. Tricky part with benchmark is like, I don't think any of us are really aiming for average. So that it's an average, right? And so you're aiming to be middle and then at best. And then the other tricky part about benchmarks is they also include moonlighting. And so you can't really differentiate what a garden variety hospitalist job should be. So I would say take benchmarks with a grain of salt because there's issues with them. But I will say high level C-suite level leaders really lean on them very heavily. And then if you can, if you have Epic Signal as well. So you can look at patterns of your clinicians. So look at your typical person who's doing a day shift. What are they being paid to do? Is it 10 hours, 12 hours? What does that workload look like? If it's exceeding, then that's another snapshot view of what you can show. I've taken length of stay data, which ultimately costs you millions of dollars if your staffing strategy isn't right. And then there is a paper on the cost of turnover for hospitalists, which was much lower in the outpatient world. We're working to update that to see if 50,000 is really accurate because it didn't incorporate those patient care costs. And so what we've seen in some of our other work that experience matters. So if you have turnover, younger folks are going to have longer lengths of stay till you hit the sweet spot of experience. So there's real costs to not having enough staffing or having an experienced group. Anyway, I don't want to take too much of your time, but I'm happy to meet after and we could run through different strategies that I've used at least.
Thank you, Dr. Burden. Really appreciate that.
Yeah.
Thank you, Dr. Burton. I had a question looking at this slightly differently, and I hate to sound like a negative Nancy, but what are some interventions that institutions have put in place that have failed? Looking at, we don't want to reinvent a wheel, especially when it's a square wheel. What doesn't work?
Yeah, well, it depends on how you define fail. But, like what I worry about, what we've learned about our third party consultants who are really good people. But I've learned that, most of them don't pull patient outcomes data, right? They have very digital footprints of like things done. So it's usually encounters and work reviews. I think that is a fail to not take a larger view. So our entire system across the entire United States is often based on how many things that did you do, not linking it to does that drive better outcomes or not, and what is that breaking point. So I would say that we're all at fault at that, and I think you can use work reviews and encounters as a piece of it, right? Like we're going to be beholden to that. It's not to say not to do that, but that is your sole strategy. I think can be misguided. So you can start there, but then start to ask yourself, if we want to be number one in the country, which I assume you guys do, just like we do, how do we get there? And it's probably not doing what everybody else is doing. And then I think about like what are these low kind of low yield strategies that we inflict on people. And in the hospitals world, I mentioned the early discharge stuff. Yes, we want to get people out, but it's one of the highest cognitive load tasks, highest risk things that we do, and it gets trivialized. So one of the most interesting ones in my career was like just take a quick 5 minute break from rounds and discharge in real time. Highly complex, high cognitive load task. I'm like, you're just waiting for a patient error, a bad outcome to happen. And so thinking about, yes, we want to have throughput, but is that the optimal strategy? And so I really look further upstream, which is structure and process of work to help highly talented individuals do their job in the best way possible.
Wonderful. Fantastic discussion. There is one more hand up. I don't have the name of who's on this mobile call, but we're a little bit past the top of the hour. I want to be respectful of everybody's time. And thank you so much, Dr. Burden. You clearly elicited a lot of passion in response to your wonderful talk. Thank you very much.
Thank you.